acute kidney injury and any updates in acute kidney injury. So bear with me too, because I'm using Juan's computer. So if any strange text messages pop up, it's not me, it's Juan. So the learning objectives for today's talk are to define and stage AKI for a given patient, to discuss the impact of timing, modality, and intensity of renal replacement therapy on patient outcomes in AKI, to evaluate the appropriateness of different CRRT solutions ordered for CVVHDF for a given patient, talk about PK changes in AKI, and evaluate the effectiveness of current antimicrobial dosing strategies in CRRT. So to start out with, I think most of you are familiar with the KDIGO definition of AKI, and how this has evolved over time is initially we had the rifle classification of AKI, which was a 1.5 increase in serum creatinine defined as risk, injury being a 2-fold increase in serum creatinine, and failure being a 3-fold increase in serum creatinine. And then the AKIN group, which Dr. Maida is part of and helps to lead here from UCSD, recognized the need to define AKI as smaller, more subtle changes in serum creatinine. And that's where the definition of the 0.3 milligram per deciliter increase in serum creatinine over a 48-hour time period came about. And then the staging of AKI follows kind of the rifle classification, if you will. And then the KDIGO guidelines put together the work that was done with rifle and AKIN, and then helped to kind of further refine those definitions by working on some of the pediatric definitions of AKI. So what does this all mean when it comes to the epidemiology of AKI? So what I can tell you is that the data is actually very confusing. And when you try to understand the epidemiology, it's important to know that it's changed because the definition of this syndrome or disease has changed. So one of the largest epidemiological studies came out a couple years ago from the Best Kidney Investigators, looking at 29,000 ICU patients. And they found an overall incidence of AKI of about 5.7%. And this was using the rifle criteria. And you can see that 10% of patients had risk, 5% injury, and 3.5% with failure. And the most common etiology, which is very known to us, is septic shock in that cohort. And of interest to me in terms of my own particular research is drug-induced AKI and the contribution of drugs to worsening AKI. That was found to be about 19% in that cohort, with an overall hospital mortality of 60%. The AKI EPI study is a more recent study that was published by Host and colleagues, and that was published just a couple years ago. 1,800 patients using the KDIGO AKIN definition of AKI. 57% of ICU patients had AKI, with 18% in stage 1, 8.9% stage 2, 30% stage 3 AKI. And what was interesting and something that we as hospital-based clinicians don't always pay attention to is a large portion of patients had incomplete resolution of AKI at hospital discharge. And it's these epidemiological studies that have led nephrologists to worry about that discharge of that patient with an incomplete injury and the follow-up. Is there any follow-up with a nephrologist in the outpatient setting? So hence kind of the development and the growth of what we call AKI clinics or AKI follow-up clinics, where patients are now being followed for the first 90 days after an AKI injury to see if they've progressed to develop CKD or whether their injury has fully resolved. And in this cohort, drug-induced AKI was about 14%. So what are the overall kind of KDIGO strategies for or recommendations for the treatment of AKI and prevention of AKI? So this is just a nice graphic that is in the KDIGO guidelines that shows you how to kind of treat it based on risk and then the different severity of AKI. And these are all things that we all know. It comes intuitive to us, but how often do we actually put it to practice? So discontinuing nephrotoxins when possible. this is really a frequent contribution to acute kidney injury. And we as clinicians, when we have a very sick patient, do everything that we can to manage that patient. But we have to be mindful that each additional drug is increasing their risk for the development of acute kidney injury. Ensuring volume status, perfusion pressure, functional hemodynamic monitoring, and then just the simple kind of monitoring of our biomarkers that are needed. And then it's not until we hit stage 2 or higher that we start to alter drug dosing, we consider renal replacement therapy, etc. So one of the first things that we do in the treatment of AKI is administer fluids, right? So largely patients may be volume down, dehydrated, and are pre-renal, if you will, in terms of their AKI classification. So the administration of fluids helps to increase intravascular volume, restore renal perfusion pressure. Well, what fluid is the most appropriate fluid? This has been kind of an area of interest over the last few years. We almost always use sodium chloride or a crystalloid for volume replacement. And what people have been interested in is that large volume sodium chloride infusions may actually be deleterious, that they worsen acid base because of the chloride load and may lead to kind of worsening AKI outcomes, if you will. So people have been studying, is there other fluid replacement strategies that are better or superior? And so far we haven't seen a superiority. The SPLIT study looked at the incidence of AKI when comparing sodium chloride as a replacement fluid compared to Plasma-Lyte or other kind of balanced salt solutions. And they found no difference in the incidence of AKI. Colloid solutions are always of interest because most often the patients will have hypoalbuminemia, decreased oncotic pressure, interstitial fluid accumulation, and so the thought is to give colloids, restore the oncotic pressure, and help to kind of diurese off that excess volume. Well, if you look at the outcomes in comparison of albumin to sodium chloride, again, no difference on mortality between those fluid replacement strategies. So the KDIGO guidelines suggest that in the absence of hemorrhagic shock, isotonic crystalloids are the fluid of choice for intravascular volume expansion in the setting of patients who are at risk or have AKI. What about diuretics, and how do diuretics come into play in managing that AKI patient? Well, definitely, we all know that diuretics facilitate volume management. So in the setting of fluid overload, helps to kind of pull off that excess fluid. But many people have been interested in investigating the renal protective effect of loop diuretics in reducing oxygen demand and kind of improving the clearance of necrotic debris that's in that injured kidney. And large RCTs have showed increased harm, actually, in patients who are receiving furosemide to prevent AKI after cardiac injury or those that have been exposed to contrast. And so far, systematic reviews have shown that furosemide does not reduce the need for renal replacement therapy or reduce mortality when used to treat AKI. And so the bottom line is that KDIGO recommends not using diuretics to prevent AKI, a strong 1B recommendation, and not using diuretics to treat AKI, except in the management of volume overload. So that's just a very nice subtle point there. But the point is not that you should not try to use a loop diuretic to convert anuria into oliguria, but rather use the loop diuretic to manage volume. So I hope that that is a distinction that's acceptable. Vasopressors. So oftentimes we'll give fluid replacement and we still have persistent hypotension, and that really places the patient at risk for decreased renal perfusion and development of AKI, and we all know that vasopressors can improve that renal perfusion if we do have adequate fluid resuscitation. But what's not known is what is the ideal vasopressor in the setting of the AKI patient. Is one more effective than the other? And so there have been several studies kind of looking at this. The SOAP2 investigators I'm blanking on his name, the principal investigator. Do you remember him? He's from Europe and has the accent, and he's super funny. Comes to our CRRT meeting every year. Anyhow, they looked at the comparison of dopamine versus norepinephrine and whether there was any improvement in renal perfusion with dopamine. They found no difference in mortality at 28 days, and they found a trend to worsening adverse effects, specifically in the cohort of patients with cardiogenic shock, more arrhythmias with dopamine. So no superiority for dopamine in the setting of AKI. The VANISH trial investigated renal replacement therapy needs in kidney failure when comparing vasopressin to norepinephrine and found no difference in kidney failure-free days between those agents. So in summary, KDIGO recommends the use of vasopressors in conjunction with fluids in patients who have vasomotor shock who have AKI or at risk. And KDIGO recommends not using low-dose dopamine to prevent or treat AKI. And KDIGO also suggests not using phenoldiprem to prevent or treat AKI with a lower grade recommendation on that. So what about renal replacement therapy? Renal replacement therapy is generally needed in about 5 to 6% of critically ill patients who develop AKI. It's associated with increased mortality, increased hospital costs. Despite advances in renal replacement therapy, there's still tons of questions that need to be answered in order to optimize that therapy and improve outcomes. So the questions that are thought about by nephrologists when they're prescribing and implementing renal replacement therapy are timing. When do we start the renal replacement therapy for that patient with AKI? Which modality do I use? Do I use IHD versus CRRT? And then within CRRT, is there a preferred form of clearance? And then what's the optimal treatment dose or intensity of therapy that should be delivered to that patient? So those are all important questions that haven't been fully answered, but there have been several studies now that have tried to answer that question. And here's one of them. I'm not sure if you can see this easily or not, but this is the ELAINE study. So this was this is a study of patients who are critically ill, who have developed stage 2 AKI, and then they were randomized to early versus delayed initiation of renal replacement therapy, with early initiation defined as 8 hours of having met stage 2 AKI criteria. So that's relatively early. That's a doubling of serum creatinine, and then 8 hours later, starting CRRT, okay? Versus the delayed therapy is 12 hours of having met stage 3 AKI, or the tripling of creatinine, which is kind of more the traditional approach, one would say. So this was, I have to point out, a single center study that came out of Germany. The other criteria that they used is they used a new kind of more novel biomarker of AKI injury, which was plasma NGAL. And they used a plasma NGAL cutoff of 150 or higher, which is predictive of the development of AKI. So what were the outcomes from the ELAINE therapy? So I don't think, do I have a pointer? I don't know if I have a pointer. I'm sorry. Oh, jump on the stage, yeah? Okay. Okay, so in terms of overall mortality, so this was mortality at 90 days. You can see the orange graph is early replacement therapy, and I'm worried about the video conference. And the delayed graph is the blue line, or delayed renal replacement therapy. And they found a pretty significant difference in mortality when you implemented CRRT at stage 2 versus stage 3 AKI. So many people, this is quite controversial, and many people are actually wondering, how do you see such a huge difference in mortality? This is kind of a little unexpected for the population that we're treating. And so I think that whether the question of initiating renal replacement therapy that early or not has not been fully answered, because there are other studies that kind of contradict this. But again, there's a theme that there might be still questions of when is the most appropriate time to initiate renal replacement therapy, and it may not be necessarily the time that we traditionally do it. The AKIKI study group also looked at the impact of timing, And this was a multi-center study, a randomized trial of patients who had severe AKI. So all the patients in this study population had stage 3 AKI, or that tripling of serum creatinine. They were vented, they were on vasopressors. These were sick patients. And they tested, the randomization was that they tested an early strategy of you just met the criteria for stage 3 AKI and then you get randomized, versus you met the criteria for stage 3 AKI, but let's wait for the development of uremic symptoms, let's wait for the development of severe hyperkalemia, severe metabolic acidosis, etc. So it was symptomatic, significant symptoms versus meeting the criteria of a tripling of serum creatinine or urine output criteria. And what you can see, and again, the time frame for this, the mortality outcome is actually 60 days in Akiki versus 90 days in Elaine. And you can see no difference in these two strategies for mortality in this patient population. However, the delayed strategy had a greater proportion of patients who were free from renal replacement therapy. So what that sums up, or what that means to us, is that the delayed versus early initiation in a very sick population doesn't change mortality, but there might be some patients who just got away with not needing renal replacement therapy. And that's kind of what I take as the bottom line from that message. So we're still not doing a wonderful job of understanding who those patients are and who we can delay versus who really kind of needs it early on to make an impact on mortality. So that's timing. What about modality? What about, does IHD, is that better or is it less superior to CRRT? So this was a study that was done by Dr. Maida. This was a multi-center study, but again, kind of limited to California. I think it was Irvine and us and the VA. And they looked at the impact. This was observational prospective study. They looked at the impact of IHD versus CRRT on mortality, and there was no significant difference in the overall cohort between IHD and CRRT. But if you looked at patients according to their Apache score at randomization between those two modalities, there might be a slight benefit, towards IHD actually versus CRRT. And then Scaffold and colleagues looked at modality and compared patients receiving CVVH versus IHD and found a difference favoring actually CRRT or CVVH in terms of mortality in ICU patients. And then Liang and colleagues looked at the impact of modality on renal recovery, because that was also another question that was unanswered. And they compared 90-day renal recovery and 1-year renal recovery between CRRT and IHD, and they found a benefit towards CRRT for improving renal recovery. But when that renal recovery was adjusted for multiple covariates in a multivariate regression model, you lost the significance towards that benefit. So there's still, again, some unanswered questions, but some trends towards slight improvement with CRRT. I lose that animation. I lost that animation. But the bottom line is that KDIGO recommends the use of CRRT in patients who have hemodynamic instability, and there's really no superiority of IHD over CRRT. It's just really left to the nephrologist to choose the appropriate modality that the patient can tolerate. So what about intensity of renal replacement therapy? So this is the VA Acute Renal Failure Trial Network study that looked at high intensity and low intensity renal replacement therapy, and they looked at IHD or SLED as well as CRRT, and they defined high intensity IHD as 6 therapies per week, CRRT as an effluent of 35 mils per kilo per hour, versus the low intensity, the traditional IHD 3 times a week, CRRT at 20 mils per kilo per hour. and this was a large multi-center prospective randomized trial that found no impact of high-intensity renal replacement therapy on all-cause mortality at 60 days. This again was studied by the RENAL study investigators looking at high intensity in CRRT, 40 mils per kilo per hour versus 25 mils per kilo per hour. And again, mortality at 90 days, no impact, no difference with high intensity CRRT. So there's been several studies now looking at intensity, and the trend is towards no impact on overall mortality with increasing renal replacement therapy, leading to the KDIGO recommendation of using a targeted KT over V of 3.9 per week for IHD and 20 to 25 mils per kilo per hour for CRRT in AKI. But the one question that has kind of, or the one issue that has kind of come to light that I don't know how many of us as pharmacists really appreciate is that the dose that's been prescribed by the nephrologist is not the dose that's been delivered to the patient. So when you have a patient who's starting CRRT and Dr. Shabinska is rounding on a service and she prescribes, a dialysate flow rate of 1 liter per hour and an ultrafiltration flow rate of 1 liter per hour and the kind of the standard 2 liters per hour, that's not necessarily the prescription that's delivered to the patient. And several studies have documented that the actual dose delivered to the patient can vary between 70 to 80%. And the reason for this is that there can be significant downtime in the range of 3 to 7 hours, with the primary reason being filter clotting. So when that circuit clots and it goes down, it takes a good amount of time for the dialysis nurse to come back to the ICU and set up that filter again. And that all leads to reducing the efficiency of the dose that's being delivered to our patient. What does that translate to us as pharmacists? That's when you start to see that funky PK, that Vanco clearance that doesn't look like the normal clearance that we anticipate with 40 mils per minute of CRRT that we think we're giving. Right? So that's because there's been downtime for CT scan, there's been downtime for filter clotting, et cetera. And you really have to look at the dose that was delivered to your patient by using the CRRT flow sheet, and I'll show you that in a moment. So switching gears to the CRRT circuit, we'll talk a little bit about logistics and the different solutions used. So for those of you who are new to UCSD, so specifically our residents, just so that you know, UCSD, Dr. David Ward and Dr. Ravi Mehta actually came up with the first anticoagulated CRRT circuit using citrate anticoagulation. This was patented back in 1989, I believe it was. So they do have a US patent on this circuit. And what they designed was that they, in place of heparin, replaced heparin with trisodium citrate for anticoagulation, and then had to redesign the dialysate and all the replacement fluids to complement that citrate anticoagulation. So this is just a picture courtesy of Dr. Ward from the original whiteboard design. So why use citrate anticoagulation? Calcium is needed for both the intrinsic and extrinsic pathways for coagulation. Citrate binds calcium and helps to anticoagulate the blood. It's associated with better circuit survival, less bleeding. It's more biocompatible within the body because it's metabolized to bicarbonate by the liver. And it may be associated with increased costs, and in the past was associated with a need for customized solutions, but we've gotten around that. The different citrate solutions that are available are the 4% trisodium citrate, and then ACDA and ACDB. Numerous institutions have come up with other protocols using diluted forms of trisodium citrate. So if there's ever a question about, could we use 2%? My nephrologist wants to prescribe 2% trisodium citrate, et cetera. There are protocols that have been published from UAB, so feel free to call us and ask. We can share those with you. The main issue with the use of 4% trisodium citrate is the sodium concentration. It's 408 milliequivalents per liter. ACDA is 224 and ACDB is 135. And the main disadvantage of using kind of the other solutions, ACDA and ACDB, is that they contain some dextrose. So you're consistently adding to that glucose load in your very sick ICU patient. So what about the dialysate and what about the choice of buffer? This has been kind of an area of interest recently because we have no bicarb all the time, it seems like. So there are three major buffers that you can choose from. There's acetate, there's lactate, and there's bicarbonate. Acetate is no bueno, as one might say, because of the risk of accumulation of acetate, and it has kind of negative impact on myocardial performance and demand. It acts as a peripheral vasodilator, causes a lot of hypotension. Lactate is better. It's converted to bicarb on an equimolar basis by the liver under normal physiologic conditions. But lactate itself in the ICU population is associated with a higher protein catabolic state. So your patients may end up chewing up whatever protein stores they have, if you will, to deal with the stress. Bicarbonate is our major physiological buffer that's produced by the kidney, so it's the most biocompatible. The challenges in the past were to make it commercially available because of its short stability and the risk of precipitation. But many manufacturers have gotten around that. Most of the dialysate solutions now have a two-chamber bag, so an inner chamber with bicarb and then the rest of the base solution, and you break the inner chamber, release the bicarb, and kind of shake it up prior to its use. So, all of these buffers can get converted to bicarb. It's just that bicarb is what we produce in our body, right? And it's kind of the most physiologic approach. The issue with acetate, you need a good, healthy liver. You need skeletal muscles that can convert it, that aren't under a bunch of stress. The issue with lactate is you need good, healthy livers, etc. So in the absence of liver disease, if you really are short, you could use lactate adequately, okay? But you have to be mindful of these considerations and be monitoring your patient for adverse effects. So this was a study that was done looking at the impact of bicarbonate replacement fluid versus lactate replacement fluid on lactate concentrations, on bicarbonate serum concentrations, and base excess. And what you can see is that bicarbonate performs pretty close, or lactate performs pretty close to bicarbonate. The one limitation to lactate is if you can't metabolize that lactate because of liver insufficiency, you will start to accumulate lactate in the blood. Lactate is an anion, it's a strong anion, and will contribute to metabolic acidosis. So you just have to be mindful of that, and in the setting of a shortage, we don't have a lot of choices or options, but those are the downfalls. And so we as pharmacists, as much as we can do as possible to source bicarbonate and to plan proactively for that is incredibly important. So KDIGO suggests using bicarbonate rather than lactate as the buffer in dialysate and replacement fluid. It recommends using bicarb rather than lactate, specifically in patients with circulatory shock. And it also recommends using bicarb rather than lactate, specifically in patients with liver failure or lactic acidemia. So some of the challenges that we had in the past with citrate anticoagulation was that we had to have these customized solutions, and there were a lot of workload implications and potentials for error. And then after we got that all figured out and we had this perfect circuit, then we had drug shortages, right? And drug shortages have been this constant challenge for us in the delivery of adequate care to critically ill patients. So due to critical shortages in sodium bicarb, calcium chloride, and sodium chloride, which always boggles my mind, we have had to redesign the citrate CRT circuit. So this is a schematic of the circuit, kind of how we redesigned it in the face of shortages. And you can see that we use trisodium citrate anticoagulation at a rate of about 140 mils per hour or even less. We use a pre-filter substitution fluid, and that pre-filter substitution fluid is important to kind of maintain a certain dilution of the blood to help to minimize filter clotting. So if you didn't put any fluid pre-filter and we start to pull off water through the hemofilter, we're going to hemoconcentrate the blood, increase the risk of clotting. So we do have to dilute the blood to some extent, right, before it hits pre-filter. The issue with diluting the blood and using all of the substitution fluids pre-filter is that if you put too much fluid in pre-filter, you reduce the efficiency of the hemodialyzer to UF the patient and pull off kind of the excess toxins. So you have to, it's like a fine balance. And that's why we do about 500 cc's per hour of some sort of pre-filter substitution fluid. And the one that you choose is really going to depend on the acid-base balance of your patient, what you have on stock or on hand, and what your dialysate looks like. Okay, because you're just being mindful of, do I give base or do I not give base? Okay. And then the blood pump is about 100 mils per minute. Citrate is titrated to a post-filter ionized calcium. So this is important for the residents. You will have a total serum calcium, you will have a post-filter ionized calcium, and you will have a systemic ionized calcium. The post-filter ionized calcium target is 0.35 to 0.45. That's to just kind of maintain anticoagulation of that circuit, okay? So that's your target to anticoagulate the circuit blood, if you will. But because citrate is mopping up calcium, you run the risk of hypocalcemia. So we measure a systemic ionized calcium and a total calcium as measures of the patient's calcium stores, if that makes sense. And then we administer calcium chloride as a continuous infusion, and nowadays it's also shorted, so we administer whatever we have. And we give some post-filter fluids, about 200 mils per hour. I think that's to maintain the aeration chamber in the CRRT machine. And then post-filter substitution fluids. And again, this has become a challenge in terms of us not having bicarb and being able to give base back to the patient. But the substitution fluids will be ordered by the nephrologist based off of the acid-base balance of the patient. So they'll look at the patient's pH and their bicarb levels, look at whether they're mechanically vented or not, and then decide, how much base that patient needs. And then the volume of that is going to be determined based off of whether the patient's euvolemic or needs to be volume up or down. So we've had some challenges in terms of the substitution fluids not having bicarb. And again, that's where we turn to whatever commercial products we have like Prismasol, or we can use lactated Ringers as a replacement fluid. For our dialysate, we've switched over to a commercially available dialysate, which is great. Gone are the days that we had to compound this baby. That was really hard on our techs. I remember them having repetitive hand injuries just from having to inject, all of the additives to the bag. So Prismasate BGK4 is about 32 MEQs of bicarb per liter, has 4 MEQs of potassium, 2.5 of calcium. And the main thing to consider is that all of the Prismasates are either 32 or 22. So there's a higher bicarb and a lower bicarb. And then they'll have varying potassium concentrations depending on whether the patient's running low on potassium or running too high on potassium. So the physicians will order this kind of depending on what's going on. Oh, wrong button. Okay. And then replacement fluids, we talked about normal saline. And when we had bicarb, we used to do half NS plus 75 of bicarb. And when we had a lot of bicarb, sterile water plus 150 of bicarb. And then you have the lactated Ringers, and it provides about 28 milliequivalents of lactate that hopefully gets converted to bicarb. And then this is just a table showing you the different Prismasols for replacement solutions. I also have tables of Prismasate, so if anybody wants those, I can give them to you. And again, the Prismasol replacement fluid comes in a 22 or a 32. I don't know that you would ever use the 22 because we're looking for as much bicarb as possible. If you think about our old bicarb fluids, they were 150 milliequivalents of bicarb. All we have at best is 32 here, right? So it's a bit of a challenge in delivering a buffer to the patient. So what are some of the complications of CRRT? So the interesting thing about CRRT in that AKI patient is over several days, the patients will actually lose quite a bit of electrolytes. So they can become hypophosphatemic, hypomagnesemic, etc. So in the past, we had talked about having a specialized electrolyte replacement protocol for these patients. I don't know if that ever came to fruition. I think we just used the regular ICU replacement protocol. And then the other challenge is citrate lock. So this is a situation where patients have liver failure and can't metabolize the citrate, and so they will start to accumulate citrate. And you see this because the post-filter ionized calcium starts to drop, maybe it's 0.2 or lower, but the total calcium is rising because you have citrate complexed calcium that's accumulated, and the serum calcium assay can't distinguish the two and picks it up in the bound calcium concentrations. So what do? You either reduce the citrate flow rate, you hold it, or you can try to increase the UF and ultrafilter off that excess citrate. Patients, I don't think they ever get alkalotic anymore. Once in a blue moon. And really the only thing you can do is one of the old recipes that I always include that I think we've only done once is a hydrochloric acid infusion, which scares the daylights out of a lot of people because I don't know why as pharmacists we're really scared of hydrochloric acid, but you can give hydrochloric acid to a patient. Dr. Ward kind of came up with this recipe of using a 0.2 molar, or I would probably even use 0.1 molar, 100 mils per hour continuous infusion. Nutrition, there's protein loss across the hemofilter, trace element loss, so you don't have to reduce your trace elements. You need to give a little extra protein. Those patients are catabolic and you'll lose some across the filter. There's been a lot of interest, and I believe there are guidelines specifically for CRRT and nutritional deficits. And then filter clotting, we talked about downtime and drug dosing. So now I'm going to switch over to drug dosing for the last bit of my talk. So medication dosing in CRRT is a challenge. And I always kind of think of like Mary Poppins and a little bit of magic when we're doing it. So it's a bit of an art. So the Food and Drug Administration doesn't require pharmacokinetic studies of drug dosing in patients with AKI or those requiring CRRT. That's a problem, right? All they require is drug dosing PK studies in chronic kidney disease. And then we're expected to extrapolate those findings to an AKI patient or a patient on CRRT who's septic and really sick. So PK studies in CRRT are largely driven by investigators and academic institutions, but so far they only represent less than 20% of marketed drugs. And you know, they're small studies, single center studies, small patient populations. And the drug dosing recommendations in terms of extrapolating from CKD to AKI don't work because AKI often occurs in multi-organ dysfunction. So you can't just look at the kidney in isolation and try to come up with some sort of dosing strategy, because in the setting of AKI, there's inflammation, and all that inflammation impacts the function of other organs and how the organs talk to one another. We already know there's tons of evidence for organ crosstalk. Heart, kidney, brain, kidney, lung, kidney, they all talk to one another and kind of impact each other's functions. So the attainment of target concentrations is quite challenging in this population. How does AKI alter absorption, distribution, metabolism, elimination? Really, drug absorption is pretty bad. So as a pharmacist, when you have an AKI patient I mean, for the most part, hopefully the ICU patient's not getting a bunch of oral meds, but you really need to be careful about oral medication absorption in this population. There's changes in gastric intestinal transit time. Uremia is going to alter gastric pH for absorption. Everybody's on some sort of PPI or H2RA, which is a problem of it in itself. Vomiting or diarrhea, gut dysmotility because of edema, because of vasoconstrictors. If your patient's been NPO for days and days and days, there's evidence of intestinal atrophy that can occur even in that period of time. And we know there's decreased first pass metabolism and decreased intestinal P-glycoprotein. So relying on the oral absorption of a medication in a sick patient, specifically if they're antibiotics, I think is risky. I think you need to be very careful in that scenario and think about preserving the IV kind of antibiotic for that specific situation, and then as they get better, switching them to orals. There are drug distribution changes during AKI. As you all know, these patients become volume overloaded, and the volume of distribution goes up for hydrophilic drugs. What we may not kind of be aware of is the impact of those volume of distribution changes. So when you look at hydrophilic drugs like amikacin or aminoglycosides, it's more than double for the volume of distribution compared to a healthy volunteer. The volume of distribution increases with daptomycin, again doubling, meropenem, again substantially changing, and as well as vancomycin. So what does that mean? That means that we probably need to change our loading doses, and that means that we may even need to change our maintenance dosing to account for those volume of distribution changes. Hypoalbuminemia and uremia will impact drug binding to albumin, and so you'll have more of a free fraction of the drug. Generally speaking, we think that a reduction in creatinine clearance corresponds to a reduction in clearance of antimicrobials or other drugs that we use in these patients. But what we don't really know is how does sepsis impact tubular function within the kidney? How does it impact reabsorption? How does it impact secretion of medications? We also don't have a very good appreciation for how non-renal clearance is impacted in AKI. We think it's impacted to a significant extent, but we don't know how that compares to end-stage renal disease. Most of the studies of non-renal clearance, so hepatic metabolism, skin metabolism, lung metabolism of drugs in the setting of renal failure have been done in the chronic population, in the end-stage renal disease population. So this is a really nice paper done by Mary Villay and colleagues, and what they did is they looked at the impact of AKI on cytochrome P450 metabolism, and this is in a rat model. They summarized all the data that's been done to date, and as you can see, the different CYP isoforms will change in a rat model of AKI. And then they also went and looked at all the data that's been done in humans. And as you can see in some instances, so if we take imipenem, in healthy volunteers or normal renal clearance, the clearance of imipenem is about 130 mils per minute. In the setting of AKI, that's reduced down to 90 to 95 mils per minute. And in end-stage renal disease, it's 50. Meropenem doesn't change all that much between AKI and healthies, but it does go down in end-stage renal disease. And you can see for vancomycin, a significant drop in non-renal clearance from the AKI to the end-stage renal disease patient. We don't know how to quantify this. All we know is we look at the pharmacodynamic impact. Are they getting better? What's the PK looking like, et cetera. But I just want to bring this to your attention that it's not just the kidney, that it's really a complex system of crosstalk between all the organs. And does implementing CRRT or instilling or starting renal replacement therapy, does that change that milieu? Does it change non-renal clearance? Because it's conceivable that when you start CRRT and you start to remove these toxins, that maybe the organs can kind of function a little bit better. You reduce that inflammation, et cetera. And this has been shown in kind of small studies looking at telithromycin concentration exposures in patients who have AKI and comparing them to healthies, and then starting renal replacement therapy and showing kind of that improvement in activity. Nolan from Pittsburgh showed a 27% increase in the erythromycin breath test as a surrogate for CYP3A4 activity when you started renal replacement therapy for 2 hours. Right? So that's kind of significant. We don't know how to quantify that. We're just starting to scrape the surface in terms of research in this area. What about drug transport in the kidney? Can that injured kidney still transport drugs across the proximal tubular cells? We know that there are really important transporters in the kidney, O1, O3, OCT2, and P-glycoprotein as examples. And there's very little data. We think that there's P-glycoprotein suppression during AKI, so drugs that get transported into the tubular cell get locked in there and may cause additional damage. That's the implication. But there may also be reduced O1 and O3 expression, and most of this data is coming from rat models of AKI. So we have really no human data to help guide us in terms of kind of mitigating this risk. How does CRRT remove drugs? How do you know if that drug is going to get cleared off? There are drug-dependent factors: protein binding, volume of distribution, molecular weight, and the drug charge, which is not really that clinically significant. Therapy-related factors: the type of modalities, CVVH, CVVHDF, CVVHD, the effluent flow rate, the blood flow rate, fluid replacement strategies, and the type of filter that you use. So drugs that have a high degree of protein binding, so I use a cutoff of 90%, are unlikely to be removed by dialysis because it's only that free or unbound drug. And protein binding is probably the single most important determinant of clearance. If there's anything you can look at, it's probably protein binding. So what many PK studies will do is they'll measure what's called the sieving coefficient. And the sieving coefficient is the concentration of drug that comes out in the ultrafiltrate versus the concentration of drug that's in the plasma. So how much kind of got filtered off or sieved by that hemofilter. And for the most part, if you don't have PK studies to guide you on the sieving coefficient, you can use the protein binding as kind of a surrogate of that. So the sieving coefficient can be estimated as 1 minus the fraction unbound of the drug. Although there have been studies that have demonstrated that the actual measured sieving coefficient differs from what you estimate because of changes in protein binding in AKI. Okay, so what about volume of distribution? So drugs that have a small volume of distribution are going to be in the intravascular space, and they're going to be in the blood available for dialysis to remove them. So if they have a large volume of distribution, they're outside of that vascular space, it's going to be a lot harder to remove those drugs. So I use a cutoff of greater than 1 liter per kilo, but when you think about the intravascular compartment, it's like how many liters in the body? 3 to 5, 3 liters of blood, that's getting cleared at a time. So really drugs with large volumes of distribution, you can kind of use that as a guideline. They won't get removed easily. Molecular weight is no longer a big determinant. Most drugs are pretty small, 500 Daltons or so they're all going to get removed, and the filters have big pore sizes. They can remove Dapto and Vanco, etc. So some principles to guide you for medication dosing. Estimation of renal function in AKI, not on CRRT, super challenging, right? So if you had a patient whose creatinine went from 1.2 to 2.5, what are you going to use to estimate their renal function? What equation would you use? Somebody throw something out there. I mean, it's okay to talk about it. So, sorry? Okay, so you could use the Joliffe equation to estimate renal function. So yesterday 1.2, today 2.5. You use the Gillespie equation, and maybe it comes out to be about, I don't know, would you say 30 mils per minute? But think about what's happened dynamically in the kidney. If you went from a creatinine of 1.2 to 2.5 in 24 hours, what would have to be the GFR to have that resultant change? 0. You would have to have like almost no kidney function to double your serum creatinine in 24 hours. And that's the thing that really trips us all up as clinicians, is that we use these equations day in and day out, but we have to remember that these are steady state equations for the most part that underperform in the setting of AKI or dynamic changes in kidney function. So just think about it mathematically, and you think about your kind of curves and relationships, if you will. So what's on the horizon? Real-time GFR measurements. Companies know that we're really bad at this. We can't quantify kidney function. So they've come up with devices to tell us kidney function in real time. This is super exciting. There's a transdermal GFR measurement device from MediBeacon that is being currently studied and investigated. So as a pharmacist, I'm jumping up and down because now I don't have to calculate or estimate GFR. I'm going to have a real-time GFR measure. Not approved yet, but coming. So what do we do in the meantime? So it's a bit easier if you have dialysis prescribed, because then you kind of look at what did that nephrologist do for renal replacement therapy. And if the patient has any intrinsic renal function, you try to quantify that and then add that to whatever kidney function is coming from the renal replacement therapy, normalized for protein binding of the drug. And then when you look at those drug databases, when you go to your CP online, you need to remember that those dosing recommendations are coming from the CKD population. So they're not going to be very accurate. They're a place to start, but not, the most accuracy. And then sometimes they result in errors. And the errors occur in drugs that have significant tubular secretion or reabsorption. And I'll give you an example of that. Fluconazole comes to mind. So this is a key kind of table for you guys, for the residents. So when you're going to estimate clearance for a specific drug, you're going to look at the effluent rate that was in the CRRT flow sheet. And then if it's for a specific drug, you can multiply it by its sieving coefficient. For PD, we generally use an estimate of less than 10 and IHD less than 10, just as general. This is what the CRRT flow sheet looks like. I don't think many pharmacists actually use this for drug dosing. Does anybody? No. Yeah, so on the CRRT flow sheet, there's the effluent, and that's telling you how many mils are coming out per that hour, and you can get a roll up, I believe. Does it sum up? It sums it up for you for the 24-hour period, and then that's your clearance. You just convert that to mils per minute. So that effluent of 2367 plus 2448 plus 2698, you add up those sums for a 24-hour period, divide by 24 hours, divide by 60 for mils per minute. That's the clearance, the modality, that's the clearance that's delivered for that modality, as opposed to applying what you think was prescribed, or what the UCSD rule is of 40 mils per minute, right? We know studies have shown that you're not getting what's been prescribed because of filter clotting and downtime. So I would really encourage people to change their practice to look at the effluent flow rate and to base it on what's actually been delivered to the patient. So kind of a step-by-step approach. We published this little review paper kind of with some guidance, if you will. So evaluate the primary literature, ensure that whatever study you're looking at is the modality that we do here at UCSD, and remember to use the effluent flow rate. If you have therapeutic drug monitoring, use it, and use it for other drugs. So something that I tell people is that, for example, aminoglycoside clearance, vancomycin clearance corresponds real nice to renal function. And that can help guide you to dose other drugs like beta-lactams, et cetera. And then consider the mechanism of action and the pharmacodynamic target. So I'm going to skip over this. You guys kind of all know it. It's different depending on the different antibiotics, but I do want to show you a couple of studies that I hope will highlight how tricky this is. So this is a study from Robert and colleagues. This was a prospective pharmacokinetic study that was embedded into that big renal study of intensity. So when they did high intensity, low intensity renal replacement therapy, they also did a PK sub-study to see, well, what happens to our antibiotics when you do this high intensity, low intensity business. And what's important to note, this is a small study, I can't remember, I think 24 patients or so. What's important to note, so this is concentrations of meropenem in A, piperacillin in B, tazobactam in C, vancomycin in D, and Cipro in E. Look at the variability in concentrations in this cohort of patients. You have 6.7-fold variability, 10-fold variability, 2-fold variability, et cetera. So wide variability in trough concentrations. And then in terms of therapeutic targets, a higher target versus a lower target. We're not hitting the higher targets with kind of our standard dosing. And 15% of dosing intervals didn't achieve the targets. 40% didn't achieve the higher targets. 10% were excessive. And the excessive dosing is happening in beta-lactams. Okay. Beta-lactams are problematic for us. Intensity of renal replacement therapy doesn't alter their clearance as much as it does vanco. But at least vanco we measure, so we know. So mucking around with the dose delivered or higher intensity renal replacement therapy may alter your antibiotics in ways you're not expecting. This is, again, Robert's paper, and they looked at the difference between 25 mils per kilo per hour of CVVHDF versus 40. As you can see, no statistically significant differences for the beta-lactams, trend for tazobactam, but with vancomycin, increased clearance with increased intensity of CRRT. So the higher the CRRT dose that's been prescribed and delivered, the higher vanco clearance, but not so much for beta-lactams. This was a study modeling different doses of vancomycin and the probability of attaining the target concentrations of like 15 to 20 or less than 12 or greater than 25, and then the probability of attaining an AUC to MIC target of 400 or higher. And you can see that we don't, with the different kind of modeling here, we don't do a good job of getting to vanco targets. It's really hard to get to the right target for vanco without being excessive. This is not a great drug from a PK standpoint and from a CRRT standpoint. Okay, so I just want to bring that out to you guys, is that it's not going to be easy. You need to pay attention to it. I think what we do is good practice in terms of measuring levels pretty frequently on CRRT, but just be mindful it's hard to get to target. So there's been a lot of interest in continuous infusion vancomycin to get to target. And this is a nice paper from, I don't know how to pronounce the name exactly, but Kovahes and colleagues, looking at continuous infusion vancomycin. The usual dose of continuous infusion is about, 15 mg per kilo, followed by 30 mg per kilo maintenance. And what they showed is that the average doses that were needed in CRRT patients was a mean loading dose of 16 and then 23 on the maintenance infusion. And when you did that, you can see the distribution of levels. About 51% or half of the patients were in that target of 20 to 30 with the continuous infusion. 30% were under target, 20% over target. So even with continuous infusion vanco, we're only getting to target in half of the patients. And this is a critical thing, right? Target concentrations of antimicrobials in the first 48 hours of a septic patient with shock on CRRT. So we're not doing the best job in general as a community. And in this paper, they showed nicely, they replicated the fact that the intensity of CRRT, if you increase the dose of CRRT, it impacts your needs for continuous infusion vanco with the need for higher dosing and lower levels. Michael Connor from, I'm blanking now on his institution, but anyways, Michael Connor is a friend of mine. He studied pip/tazo pharmacokinetics in CRRT, and he looked at doses, this is observational, doses of 2.25 to 3.375 IV Q6 or Q12 or Q8, but whatever the standard of care was, they looked at the PK, and they looked at how often we met the target kind of trough concentration. So you can see the target peak in 78% of patients with pip/tazo, trough 39%, and then time above MIC 83% with this dosing strategy. And looking at other dosing strategies and the ability to achieve target concentrations. So using kind of normal dosing of pip/tazo will get you there, but tends to be over-aggressive and excessive in terms of target concentrations. So doses closer with the Q8 interval seem to be a bit more appropriate. What about extended infusion Zosyn? A lot of people are interested in extended infusion. This has been studied in the ICU population on CRRT as a 4.5 gram Q8 dose given as a 4-hour infusion. And 90% of patients achieved 50% time above the MIC 90. But again, when you look at these higher doses that people recommend in the ICU sick population, you do end up paying the price for excessive dosing, largely because we are not monitoring these patients for beta-lactams. So therapeutic targets for beta-lactams are achieved in 90% of patients, but greater than 50% of PK samples from this cohort, this was 50 septic patients who had 73 therapeutic drug samples for ceftaz, cefepime, meropenem, or pip/tazo, greater than 50% of the samples were excessive concentrations. And the time above the MIC weakly correlated with the CRRT dose intensity. So you cannot apply the fact that increasing CRRT will just pull off drug and so give more beta-lactam. There's a cap to that. There isn't a cap with vancomycin. You will pull off more vanco, but with the beta-lactams there is. And again, another paper just highlighting the rate of excessive dosing of about 24% for beta-lactams. Fluconazole, this is, I think, the last drug example I want to give. Fluconazole is the example of one of those drugs that you cannot apply the CP online recommendation for creatinine clearance. So if you did that, then you might be applying a dose of 200 milligrams or 400 milligrams once a day. But fluconazole undergoes significant tubular reabsorption in normal renal function, and that's lost in AKI and not replaced with CRRT. We only replace filtration, not reabsorption. So you actually need much higher doses of fluconazole because you're not reabsorbing back drug through the kidney. And this was a nice paper that showed that the dose of fluconazole needed to be 800 milligrams per day to achieve the target trough of 10 to 12 for life-threatening candida. And that's why we have a renal dosing card. So use your card. I'm looking for any volunteers to take over the card from me. And then we just published this little schematic on how to approach CRRT drug dosing. It's too small to read, so I'll go to this last slide. So just to kind of summarize, use the IV drug to bypass absorption, adjust the loading dose for hydrophilic drugs because the volume of distribution is going up in the setting of a hydrophilic drug if the patient's edematous and volume overloaded. Consider the pharmacodynamic properties. I know we're still kind of arguing the AUC to MIC versus the MIC, et cetera, or target troughs. I think in this population, it may be prudent to look at both, not just the trough, but the AUC to MIC. Look for primary literature when available because those CP online recommendations are not always going to be right. Employ therapeutic drug monitoring. Use it to your advantage. So as a pharmacist, we can order those levels per protocol. I encourage you to do that. And then don't just, look at what was prescribed in terms of the orders. Look at the parameters of the patient daily. Look at how their urine output is changing. Are they recovering? Because one of the critical, I would say, gaps is when that patient is recovering from AKI, being transitioned from CRRT to IHD, right? Then we start to think, oh, they're on IHD. But no, they're making urine. They're making half a liter of urine, and then they're starting to come off IHD. That's a critical period where you need to be careful with the drug dosing because they're starting to recover. So look at your patient every day. Any questions? Yes, Marcy.
Thank you very much, Dr. Osh. It was a really great overview. I have a question. Earlier on, you were talking about the fluid replacement and the use of sodium chloride versus albumin, and you said that there's no difference on mortality. Was there any difference on either recovery or progression of AKI?
So the question was there any, when we talked about fluid replacement therapy with albumin and sodium chloride, there was no difference in mortality. Was there any difference on recovery of renal function for AKI? Or progression of AKI? I don't know that that's been answered. I don't know that that was studied, but I can look back and check. Recovery of AKI and progression to CKD is only now being realized, I would say in the last few years, as kind of an important issue that people weren't measuring. You know, as soon as if they were alive out of the ICU and then discharged to home, nobody really paid attention to the fact that the creatinine was 1.5 at discharge versus 0.9 at baseline. You know, it was more of the creatinine's not 5. So I think people are starting to see that these subtle incomplete resolutions are not good. And where they're not good is if that patient comes back and has another hit, it's these constant kind of AKIs and, you know, that lead to progressive CKD. I don't think anyone's answered whether one incomplete AKI leads to progressive CKD, but we know that recurrent AKI leads to progressive CKD.
Those changes in CRT rates, how does that affect the drug dosing card? Is that card, does it apply to like all of the changes in rates?
No, yeah.
Those dosing cards apply to the second rates?
Yeah, that's an excellent question. So the UCSD CRRT dosing card, what does that apply to? So how do we come up with that card? We do a primary literature search of all antimicrobials on CRT and then like other miscellaneous drugs that people say add to the card. There's constant, hey, can you add this? Hey, can you? Yeah, okay. And then what we do is we apply the general UCSD CBBHDF 2 liters per hour to 2.5 liters per hour. But it would not hit those higher flow rates, definitely not. Good question. So if you have that patient where somebody's trying to do a high UF on them, your dosing card may not apply.
Have you ever involved in like the ENT approval for us to manually dose drugs? Like how does that affect like all of these different random drug dosings? It's not like you just pull up a card and apply to everybody. Like dialysis card or this CRT card. Do you involve like when you got our ENT approval to manually adjust meds? Do they have a list of just those drugs on those cards?
Wait, I'm sorry, can you say the question again? The question was, we have the PNT approved list of drugs to renally adjust, and then
outside that list, you know, like, we okay to really just all the other drugs?
oh yeah, that's a really good question. So if the drug is not on the card, can you just renally adjust it for PNT? I don't really know the answer to that question. That's kind of a Katie, Chuck, Carol question because some people would interpret it as you are covered by what's on the card. Other people would interpret it as I'm a pharmacist, I can renally adjust it, I probably can do a good job of that, right? So, and I should do it to promote patient safety. But if it was the letter of the law, I think you would stick to what's on the card. And then if it is a drug that's not on the card, you would have to page the provider for an order to change the drug. So I don't know if that's what most people are doing. Yeah. Okay. Any other questions? Questions from the residents about CR